Neither one of you look like you're at home today. John, where are you?
I'm in Los Angeles at my daughter's apartment in West Hollywood.
And how's her blossoming Hollywood career coming?
Well, it's actually she's in the process of finding a manager as we speak, and she's meeting all sorts of wild and wacky celebrities. It's an exciting time for her right now.
Terrific. And Mike Hogan, I've been in your home. That doesn't look like Albany.
It is not Albany. This is Columbus, Ohio. Go Bucks. Here for the weekend to stay with grandchildren while their parents go frolic.
All right. Well, you're both on the road. Let's get this podcast on the road here.
Let's do it.
Welcome aboard Lifelines with David and John, your guide to charting the transformative course of crisis intervention and the game-changing 988 Lifeline.
So welcome back to Lifelines, the 988 podcast with David and John, and longtime friend and mentor and amazing leader in the field, Dr. Mike Hogan, with us today. John, your reflections on the work and the friendship with Mike over the years.
It has been, I can't tell you how thrilled I am just to see Mike again. I don't get a chance to see Mike as often as I used to. Whenever I do, I not only learn things, but I laugh about a lot of things. Mike is a man of great humor, great wisdom, and just a wonderful human being. I'm so glad to see you again, Mike.
You're too kind.
Well, Mike, this is a Behavioral Health Link podcast, so we're all over the place, but we're coming from the heart of Atlanta, the soul of Georgia, and bringing a view at the legacy of crisis services and envisioning where we can go. And great to have you today. But whoever you are watching and sharing this podcast with us today, we hope you'll like and subscribe on YouTube or wherever you get your podcast. Mike, we like to start a little bit with getting a sense of our guests and some of their interests outside of work. Tell us something about yourself that maybe most of your colleagues don't know, an interest or something that is you spend your time on.
Well, these days being of, as you can tell, looking at me, of retirement age, I spent a fair amount of my time working, which is like kind of reverse. Because if you're of working age, then not working is a trip. If you're of retirement age, getting to work is pretty awesome. So I describe it as a stage of life that's kind of like being in college without having to go to classes. So I audit whatever I want and hang out. It's great.
So Mike, how often have you not been working since you left high school? Has there ever been a period?
No.
David, I'm not sure even to what extent all of our guests know who Mike is. Maybe I should give a little rundown on.
Yeah, let's do a quick bio. It's and then the hour will be over.
Yeah, it will. I mean, I have a long scroll here, but I'm gonna give it a kind of the shorter version because Mike's tenure in the behavioral health space, the public behavioral health space, is legendary. Mike has the singular distinction of serving as a mental health commissioner in 3 states, beginning in 1987 with 5 years in Connecticut. And Mike, correct me if I'm wrong here, about 19 years in Ohio, 6 years in New York.
16 in Ohio, yeah.
Oh, 16. Okay. But you of course, you chaired the President's New Freedom Commission on Mental Health from 2002 to 2003. You're president of NASHPD, the National Association of State Mental Health Program Directors, back in 2003, maybe to 2005. You were board president of the NASHPD's Research Institute, first behavioral health representative on the board of the Joint Commission in 2007. Not just so many leadership awards, national leadership awards, but my favorite things, Mike, that you've done is you've served as the Lifeline Steering Committee Chair for about a decade, and also as the co-chair with David on the National Action Alliance for Suicide Prevention's Clinical Care and Crisis Intervention Task Force. And that task force produced the highly influential Crisis Now document, which in turn gave birth to the International Zero Suicide Movement and the current Zero Suicide Institute. So you got your own consulting business now because you know a few things. And again, it's just so amazing to be here with you today.
Well, it's pretty awesome, and it's a funky journey because I guess I did all those things in mental health or behavioral health. I wasn't trained for any of it, and I was trained in management, and I guess I had some training in developmental disabilities, but I came into the mental health field through developmental disabilities and had like pretty big responsibility early on. I had no training whatsoever for that. And so the good thing about that is that I had to learn, and I had to learn as an adult. And it gave me the opportunity to learn from clinicians and learn from people with lived experience. And so I was able to do that without getting the professional training, some of which is not helpful. And then having been around a long time, you just get to do more things. So it's been a trip.
So, Mike, you led arguably the most important task force in the mental health industry's era, and you had no training for it. Is that what I'm hearing?
None whatsoever. A lot of good advice.
All right.
Yeah.
We got it. So we're still trying to learn more about Mike Hogan, the person outside of work, and we've learned none of that. So, John, it's time for our super fan segment.
Okay.
I got a blank sheet of paper here, Mike, and I'm going to write on it what I think you're a super fan of that's not work.
Okay.
John's going to do the same. You're going to tell us if we have a winner or there are no interests outside of work would be another answer, I guess. But John, let's take a shot at this. Just let's write down what you think.
Yep. And David is known by reputation as a guy who can draw amazingly elaborate things in just a few seconds. So just
okay, I'm done. John, let's see what you got. Super fan of what? Now, John, before you do that, give Mike, what's your biggest super fan thing you're invested in right now?
Oh my gosh, right now, well, I'm looking forward to my Texas Longhorns playing Oklahoma Sooners in the Red River rivalry this weekend. So yes, I'm a big Longhorn fan.
I would like to say I'm a super fan of the Cowboys, but I'm a super something. Went to bed at almost midnight on the East Coast the other night after 3 turnovers. And then got up the next morning and saw people wearing Cowboys shirts, John. So they just give you enough to. But let's do Superfan Mike. What is Mike a superfan of?
All right, I'm going to throw this one out. I'm not sure, Mike, but I've seen you in fishing gear in the past. So I'm wondering, all that time in Albany, all that extra time you got, are you out there on the ponds, in the lakes, doing a little fishing?
Not enough. You know, I'll take my canoe up to the Adirondacks, but that's for the peace and quiet and the loons. But the loons are eating the fish, and so not so much fishing unless it's with grandkids or just
with
fishing.
It's mostly hiking, looking at nature,
being outside. Yeah, being outside in the Adirondacks. You know, there are places in the Adirondacks that are nowhere near the scale of what it's like up in Minnesota, but still the 50,000 plus acre places with lots of lakes that are no motorized boats or anything like that are just spectacular. So fishing is a close second or cousin of that.
Yep.
Yeah.
All right. So Mike, I said you're a super fan of family trips with Barbara and the boys whenever you can. I don't know who's who here. I think this is Mike here. Is this Will?
Will would be the tall one. So
okay.
He's probably on the left of the screen. And John and Paul, yeah, I think so. That was a family trip in Ireland. And we did a little OHIO love. But it doesn't get much better than being with family on the road. We just this summer, the kids and grandkids all were in Amsterdam for another family thing. So yes, I would be a super fan of traveling with family for sure.
John, I did not realize, I was looking at that photo and it's clearly Ohio now that I see it.
Mm-hmm.
But I didn't realize it until now.
Have you ever seen a person in just a few seconds draw like David just did? Was that not amazing?
I think there was some secrecy and some stuff behind the scenes that we didn't see. I'm just guessing.
We're not allowed, Mike, to troll Facebook. That would be cheating. So this is just out of our heads at the last second. So,
All right.
Yeah.
Awesome.
John, this program is brought to us by our sponsor, Behavioral Health Link. Give us a quick update on the crisis software platform.
Happy to do so, David. Our guest today has been your co-conspirator in transforming crisis care in this country, beginning with producing our task force's seminal document, Crisis Now, back in 2016. And that model was heavily influenced by Georgia's statewide air traffic control crisis care system. That's a system that ran off BHL's technology infrastructure, one that was customized to coordinate care with crisis service providers across metropolitan, suburban, and rural areas. And now, the BHL platform is supporting Crisis Now models for behavioral health authorities in 12 states, efficiently connecting and coordinating care for the people they serve so no one gets lost. The platform has 988 ready modules for crisis contact hubs, for GPS-enabled dispatching of mobile crisis teams, for evidence-based follow-up care, outpatient scheduling, and crisis bed registry assures that people in crisis can connect with someone to talk to, have someone to come to them, and a place to go without waiting. If you're interested in transforming your crisis care system, just learn more about that, the BHL platform at behavioralhealthlink.com. David?
So, Mike, every week, our first segment is the good news. And we do news in the Crisis Jam, but we focus on great stuff that's happening around the crisis space. And John and I wanted to reflect today on the visit we just literally got back from with the Suicide Prevention Resource Center Executive Committee, or Steering Committee, I think they call it. And the good news we wanted to share today is the Lived Experience Initiative that Shelby Rowe is leading at SPRC. And I thought of you because we saw Will. Will was on video for the Lived Experience meeting that followed. And John, you stayed for the afternoon. So I know the three of us have a lot of love for the work Shelby and the SPRC is doing with their Lived Experience Initiative. John, let's start with you because you stayed for the dedicated session.
Well, Susie Reese, and Mike, you know this from your son, Susie Reese is kind of the mastermind right now, very much inspired by Shelby's experience as a person with her own lived experience of suicide attempts. And Susie and Shelby are creating a suicide prevention resource center that is about all kinds of experience, studied experience, scholarly experience, academic and research experience, and people who have been there and know how to translate that information into real recovery. And Mike, this really reminds me too of this is something you've always been passionate about, because I remember in 2007, we were talking about peer supports with state commissioners, and you were doing a workshop at a NASHPD convening in 2007 in Scottsdale. And you were talking about the great work that Georgia was doing in peer certification. And I raised my hand and I said, well, why don't we have some kind of peer certification for peers who have had suicide attempts and who could really assist other people who've had suicide attempts? And you immediately said, I'll resource that. And I'll never forget your saying that this was something that back in 2007, you were saying we need to have peer support in suicide prevention specifically.
Yeah. Well, it's, I was just thinking as you were talking that I came into the field basically at the same time as Judy Chamberlain's book on our own, which began to educate us professionals about and the community in general about the importance of lived experience. But then as we move forward to where we are today, I would assert that there's no area of healthcare where what happens to people is so far removed from what people have been there, who have been there, say would be helpful to them. And it's really kind of shocking and disgusting that gap still exists. And also when people are in crisis, it's the time when like they're likely to be things are going to be done to them that are not in their control, whether it's involuntary commitment, which might be necessary, or might not be, but it's done, or being put in a hospital because you're suicidal, and then you're in this hospital for a week, and nobody does anything to help you with suicidality. I mean, you get meds for whatever diagnosis you might have, but the thing that got you hospitalized was articulating that you were thinking of harming yourself, and then that you don't get any help with that. So it's the work that Shelby and Susie and her team and my son Will are doing is extraordinary, because it's in that pace, it's in that space. I think it's also they've approached it in a very thoughtful way. This is not primarily ideological. It's not primarily to be in a movement specific kind of way, but it grows deeply out of the experiences of lots of people, and it's long overdue.
Really, really great work. And your assertion, Mike, that this is one of the areas where it's least reflected. What do you think about this? This might be one of the areas where it's most important. I mean, cancer survivors have certainly been a key part of that movement over the years, but the expertise around cancer is in genetics, and so they add value, of course, but this is an area where we need them desperately to help us.
Even cancer is in substance abuse care. It's standard for persons to have had experience in recovery who are treating people, and that you don't bat an eye at that. But that is just not true in behavioral health, in mental health care specifically.
I think it's probably analogous in many ways to the experience of how advocates with HIV overturned, because they got very exercised very early on, very rightly, about how things are being done to people that didn't meet their needs, and things are being done on people that weren't helpful, and genuine needs were not being addressed. And in a way, we're not in probably quite that dire a place with respect to suicide and crisis care, but it's approaching that. So it's a transformational, I hope, impulse at the right time.
So let's shift to crisis care for a moment with our trivia question for the day. This is a Behavioral Health Link podcast, but today for our trivia, we're going to reflect on the work of Recovery Innovations in the crisis facility space. Mike, this is our new crisis facility in Wakebrook, outside of Durham in North Carolina. And this is a picture Alicia Best took recently when 5 police cars were there. Now, you were just referencing doing things for people against their will, outside of their autonomy. One of the things we've tried to do, and it comes from that Crisis Now report based upon work that Arizona was doing as early as almost 20 years ago now, is trying to interrupt that normal flow of hospitals and jails and law enforcement involvement, and having a facility that they can go to and drop someone off immediately. So, John Draper, you get the number, and Mike gets the over-under. Today, Recovery Innovations is operating 13 facilities, and some of them are in larger cities like Phoenix, but many of them are in rural and more middle markets. How many recliners, 23-hour recliners, and short-term crisis beds is RI operating across those facilities right now? And each of those means that today we could be serving, if we were to 100% capacity, we could be serving all of those individuals. How many beds and recliners is that?
So, David, you said 13 facilities, is that right?
That's correct.
13 and somewhere in the neighborhood of, I think it's somewhere in the neighborhood of 20, 25 recliners, something like that. And then there's also short-term crisis beds on top of that. So
So when I talk about a program, John, I'm talking about a short-term crisis program would be separate from a 23-hour, and the flagship here in Phoenix that's a large one. We have some large ones, but many of them are more mid-size.
So some of them do not have the short-term crisis bed.
I'll give you two examples. In Delaware, in the southern part of the state, we have a small program with 6 23-hour recliners.
Okay.
And in Phoenix, we have a larger program that has 35 recliners and 32 short-term crisis beds. So that's a pretty big swing.
Yeah, it is. It is a lot of variability there. So it's a pretty wild guess, David. I'm going to say somewhere in the neighborhood of, let's see, let's put it at 220.
220. Mike, over or under?
I'm going to guess, hopefully, that the real number is over.
It's pretty close, but it is over. And this is the dashboard that Dr. Chuck Browning, our chief medical officer, led with our IT team. So right now we have 261 across those 13 programs, and there are 163 people in those services right at this moment in time. And Mike, obviously we want that number to be higher. What we find is in the short-term crisis bed units, achieving a 90 to 95% occupancy is realistic. But in the 23-hour program where the turnover is rapid, we're challenged to get higher than 65 or 70% on an ongoing basis as you're trying to meet all of the needs. But we've done that, Mike, in an environment that is like chopping through the jungle with a hatchet. There's a lack of a regulatory framework. There's largely the lack of a payment reimbursement methodology, and doing that, building that capacity over the course of COVID has been beyond daunting for all of us in that space. So, but it's capacity is building and growing, Mike, of these key services that you and I've talked about with John and others for so long.
It's that if we could have 10 times that across the country, and it would be, if we had 10 times that, it might be 5% of the need. I don't, I'm making those numbers up, but
I think that's right, Mike. Connections Health Services has also has a significant amount of capacity, and together between us, and the other Community Bridges, Exodus, Mind 24/7, there might be 500 total in terms of beds and recliners right now, and like you said, but I frequently tell the story of John Lennon getting shot in the back in 1980 in New York and still being transported in the hospital by police car because the ambulance capacity hadn't been built yet. So we keep building it, but it does feel like 2 steps forward, 1 step back kind of thing, Mike.
It also seems like a close analogy for this might also be the percentage of urgent care facilities, the ratio of urgent care facilities in healthcare to emergency departments, and then the impact that the presence of those urgent care facilities have had on emergency departments.
Oh, that's interesting, John.
Seems to be that
I really think that's true, because this is a place where you can walk in and you don't have to stay. And if for example, you missed a refill and you're realizing that wait a minute, I need to get back on that medication, or you need to talk to somebody. You don't need to stay overnight. You certainly don't need to go to a hospital, but you need to talk to somebody to get your feet back under you. And so those capabilities, which David, some of your facilities have as well, in the same place, and other places there are places that are starting to do behavioral health urgent care that's kind of like that. I was thinking, David, as you're talking about that capacity, that we on this side of the street, I'll say, on the behavioral health side of the street, are thinking about this and thinking about the work that has to be done and the progress that's being made. But the real system for emergency care for mental health and addiction disorders in the United States remains law enforcement.
Yeah.
And we're doing some work now in Buffalo, New York, and Erie County, where people have come together. The mental health commissioner there has come together to create a crisis continuum committee, and people are at the table. And the leadership in the county has just stepped up to say, wait a minute, we want to support this effort and to hold it accountable at the level of the deputy county executive and the mayor of the city of Buffalo. One of the things that we see there is law enforcement has gotten so frustrated at the lack of capacity historically of behavioral health crisis response that they've stepped up. And so I'm not sure that they really feel a need to transfer the calls from 911 to 988. The expectation with 911 is somebody's going to see me. If I transfer the call over there, who's going to come see me? And they've now got 6 or 8 co-response teams where they, the mobile crisis response was inadequate. And so you've got credentialed mental health people that are, riding along with a CI trained officer. And so this is a response that they've had to make because we haven't been doing our job. So, and now for us to do our job right, we've got to engage with them and convince them that what we can do will meet needs and be credible and reliable.
Yeah. So, John Draper, going back to where we started, Mike actually leaned into a little bit of his origin story, but I'm not sure I got the full picture of how he became commissioner in Connecticut.
Well, yeah, Mike, it sounded almost like you just stumbled into all this. I mean, or somebody pushed you into it. I'm not sure what it was that you were in business administration, and then you somehow got into the leading the Department of Developmental Disabilities, and then somebody said, "Oh yeah, what about this?" I mean, how did all of that happen? And did you have an interest in mental health prior to
that? I'm sort of doing a check here, deciding whether I'm about to say is okay or no. I think it's okay. I think I have permission to do this, but
It's okay.
I was working in developmental disabilities in a Department of Mental Health where it was both within the same organizational structure. So I was sort of working on this side, but there was this side too. And I got asked to be director of the Western Massachusetts region of the Department of Mental Health. And the thing that was going on there was that the Commonwealth of Massachusetts had just entered into a federal court agreement to replace its then about 350 bed state hospital in Western Massachusetts with community services in 3 years. And notice I said replace, not downsize or transition. And so to have somebody lead this transition, they hired some guy who had no experience and no credentials in mental health. But ironically, within about a month of my taking on that responsibility, my kid sister had her first break with schizophrenia, and so we've kind of traveled this for 40 years together. One of us on the high road, and one of us on the low road. I don't know which road is right. So she has taught me sometimes by explaining things, and sometimes by just example. What worked and what didn't work, and she's mostly figured that out now for herself and lives a really good and satisfying life. So anyway, I get into it partly by looking for responsibility, partly by being thrust into it, and partly by having good advisors. I think also in that first role, since I had people working with me who knew what they were doing, and so fortunately they could handle most of what had to come up. But I had to learn some of it, and so I found a small handful of people, a community psychiatrist, a hospital psychiatrist, and 3 people with lived experience who I would each periodically ask for advice about stuff or take problems to, and I usually got pretty good answers and relevant to the crisis space. One of my advisors was a woman who had served in Vietnam and gotten scarred by that a little bit and was in and out of the system, and a fierce advocate, Rebecca McCauley, who used to say to me, how come when I get deep in trouble, you people are all over me, but when I just need a little bit of help, I can't just get a little bit of help, because I know when I need a little bit of help. But,
Right.
there isn't anything like that. This was a long time ago. But, now with, peer respite programs and mobile crisis, and with a Lifeline, it's possible to get a little bit of help, more on your own terms. But, Rebecca taught me that 40 years ago.
Terrific, Mike. And I'd never heard you quite phrase it that way, of this think tank that you developed for yourself as you got into this new area. Mike, you've had this long career that John referenced up front. What are you most proud of in terms of things you accomplished, either as a mental health commissioner or with the President's New Freedom Commission report or otherwise? What are the couple of things that you think have made the most difference, or you're the most excited about?
Well, good work in our world, maybe unless you're a therapist, and but all the rest of the good work is not done by individuals, but it's done by teams. And so I am really, fortunate to have been part of exceptional teams. And Lloyd Sederer, who I worked with, Lloyd was the medical director of the Office of Mental Health in New York, and was indefatigable in that role after leading the city mental health, New York City mental health program, interviewed me for something or other and asked a question that was quite similar. And the answer that came to me was to say that I was really fortunate to be able to go to places where people were about to do really good things. And that's the way so I've been really fortunate to be in places where people were about to do good things. Now, there's a sense there of not going to places that are a train wreck. So it does take some luck and talent, right, to do that. But then, sort of arriving in places where the conditions were right, but work had to be done, and work had to be done usually by a team of people who were able to come together and capitalize on each other's strengths and accomplish something for the greater good.
Lloyd is such an amazing individual. One of my favorite talks ever was a debate at National Council, like this closed door thing that I crashed. I didn't have an invite. And it was Lloyd against Ezekiel Emanuel about Emanuel was calling for thousands of new old school state hospital beds, and Lloyd's impassioned. But hey, Mike, so you've been doing this work. The President's New Freedom Commission report laid out a number of key initiatives that have had an impact on the field. I went to the robots last night, and I said, robots, give me the 7 most significant transformative developments in the mental health industry and movement since the 60s. So let's just go through those, Mike, and tell us, yeah, no, you agree, what your quick reflections are. First of all, what's the number one they said, Mike? What's your guess at? They said this was the most important since the 60s transformation in mental health.
Well, a critic of the mental health establishment once said that there's really only one fundamental policy question in mental health in America. This is not necessarily across the world, but in America. And the question was the choice between inside and outside asylum.
Yeah, of course.
And so, of course, back just before the 60s, we had 500,000 people incarcerated in state institutions. We don't have that anymore. Now we have a lot of outside asylum of people who don't have help with housing and don't have other kind of supports, and so that remains hugely challenging. Mm-hmm. But one big development is certainly that we don't have 500,000 people anymore locked up semi-permanently with not getting any effective treatment.
Yeah, and I'd say it's global, Mike. This is not just a U.S. thing, but deinstitutionalization, the Community Mental Health Act, 1963. I think coming up in my career in the 80s, I missed this second one all the time, but the development of the psychotropic medications is what it said was number 2. What's your thinking on that?
Well, that's a really mixed bag. And to some extent, I think the truth of the matter is that these treatments, while they're comparable in effectiveness with treatments for many other conditions, most of them work really well for some people, kind of well for a lot of people, and not at all for a sizable minority. And so the brain is too the brain coupled with the way we evolve and grow and learn is too complicated so far for non-personalized treatment to be very effective. And so there's no doubt that that's been it's a really big deal. And if you're somebody who's fortunate enough to have this thing work for you, it can be life-changing. But so it's a huge development, but I would say it's a very incomplete success, particularly because a lot of these treatments, not all of them, but I think of the antipsychotics, come with, side effects that are pretty nasty for many people. So we've made a lot of progress there, but we are, the National Institute of Mental Health called 1990s the decade of the brain. Well, maybe the 2040s will be the decade of the brain. We have not got the science breakthroughs yet that are able to relieve the suffering that we can relieve with other organ systems.
Mike, the third one it referenced, does this one belong at this level? And if so, how? The ADA of 1990.
Well, that's brilliant, and it's very interesting because I probably wouldn't have thought about that, but the notion that liberty shouldn't be constrained by illness or disability is a profound idea, because for a long time we didn't think of quote unquote mental illness as something that was qualifying in a sense, even though, as I said before, we had millions of people essentially locked up, and so I think that it should be number 3, or maybe it should be number 2, or maybe it should be number 1.
Wow!
Although there's promise that has yet to be achieved, but that's big.
I love that, Mike, and it goes back to your Judy Chamberlain reference and set the stage for Olmsted. I'm going to skip number 4, the Mental Health Parity Act, and the Mental Health Parity and Addiction Equity Act of 96 and 2008. But number 5 in this list, already they're saying the 988 Suicide and Crisis Lifeline ought to be number 5 in the list of 7 things since the 60s. John Draper, does that surprise you that already the robots are putting 988 that high on the impact list?
Well, they're obviously reading the recent headlines and influenced by them. I think it's early to say, but I think a few years from now they're going to say hell yes. But I think right now it's early, and I'm excited. But what we've seen with all of these other advancements, they have a history. We are in the toddler stages. 988.
Yeah.
What do you think, Mike?
Well, I was just thinking, I'm going to admit something, and I'm a little bit ashamed to admit, but that was when I came originally to the Lifelines Advisory Committee. I was a little bit underwhelmed with the impact of the Lifeline, and looking back, I can say, well, thank God. I mean, I didn't know squat about this, and to understand through the research that Maddie Gould and Brian Mashara and others did, that the Lifeline under John's leadership always supported and encouraged these deep investigations into whether this stuff is working or not, but to find that of those people who were genuinely suicidal at the time that they called, that a good 3/4 of them had that crisis substantially resolved in the course of the conversation. That is, a conversation with a capable, caring human being was enough to, in a sense, take that burden of crisis away, to hold it, to help people reflect on it, and then to give it back and to have people say, I've got this now, and I'm okay to move forward. So to understand that with that, to understand how robust that impact is, it kind of says, well, yes, this is an innovation that is that critical. Can we dream ahead to a time when not only do we have universal competent call answering, but the ability to connect people to whether it's urgent care or whether it's a 23-hour receiving facility or whether it's short-term residential stay. And we know that those other components are still grossly underdeveloped in almost every part of the country. Maybe if we get that done, we can get to a place where we can say, actually, this is number 2, or maybe this is number 1. I think, if we can make a wish and say in 10 years, how would we like this to be ranked? We like to say the ADA is number 1 and a universal crisis system is number 2. That would be something we could celebrate.
Yeah, I'm with you, Mike.
Love all that, Mike. So, Mike, so far this list is making sense to you. I'm seeing it resonates, but now I'm going to push and say, does it make sense all the way through 7, or is it a little bit like we know the news happens in our own feeds online, that it gets curated to your interests, right? So is this real, or did it shape this answer for me? That's what I'm going to ask you. Number 7, the Mental Health Reform and Affordable Care Act. I get that one. But number 6, before the Affordable Care Act, Mike, and just after 988, on the 7 most influential impacts in mental health industry and movement, the Zero Suicide Initiative. It says this is from the Robots, 2012, aimed to reduce suicide rates through a comprehensive approach across health systems. Its framework, including better care coordination, patient engagement, and focus on eliminating gaps in care, reshape mental health care delivery by making suicide prevention a core focus within healthcare settings. Either Richard McKeon wrote this, or it's real. What's your thought on that, Mike?
Well, it's very moving to think that this is emerging as something that's that significant, and both of you have carried this torch longer and more effectively than I have. So, David, I don't know who it was who said first. I don't know whether it was you or whether it was Jan Mockenstorm or whether it was John, that nobody should die alone and in pain from suicide. But there's nothing more profound that's been said about this, about a worldwide and in the United States leading cause of life to which we've been cold and we've lived in denial.
Yeah, that's a great cold and in denial. Mike, just before John goes forward, so 2 people said that same phrase within a couple of week time frame, Jan and Eduardo Vega. I heard both of them use, Jan was closer to those exact words, but Eduardo said something extraordinarily similar. And I was like, oh my goodness.
Yeah. And the Zero Suicide movement has taken off, but I don't know to the degree that it's penetrated, and I don't know, if we're at a place yet where we can say we're even close to believing it's achieving its goal. And Mike, you've done so much, as a founding member of the Zero Suicide faculty, a lot of advising, a lot of consulting with systems of care around suicide prevention and zero suicide. And I'm wondering if there's a few, when you're doing that consulting, do you emphasize a few of the 7 tenets of zero suicide you think are most important that say, you've got to do this? as you're advising leaders? What would those 2 or 3 tenets be?
Well, it's a good question. I'm reflect on it and then go to a different place, because we have, new hope now to accelerate this from very incomplete to more universal prominence. That we built this as a model using the clinical elements that the research and that people with lived experience told us was important, to be able to identify people and engage them in care, and to put them on a pathway where they could get continuous support, and to stay in touch with them, and to provide direct treatment for suicide, and then wrap that in these elements of leadership and quality improvement and training that any idiot knows are necessary for success in something complicated like this. And so my view is that zero suicide has both grown faster than any comparable behavioral health innovation that I can think of, number one. And number two, that the pace and depth of adoption is lagging way behind what we need to make this a more effective movement. But the development that I am engaged a little bit with that makes me so helpful about this is there's a brand new emergent national family foundation called Four Pines Foundation that is rooted in the care and concern and love of a couple of parents who lost a son to suicide, and who have determined to make a contribution specifically to what they call suicide care, or they talk about suicide prevention at the point of pain, which echoes back to the comments by Eduardo and by Jan, and they bring enormous means to this effort. And so they're just starting now to make initial grants to support good work in this space, including to colleagues of ours like Dave Jobs and Ursula Whiteside, whose new updated website, Now Matters Now, just got unveiled yesterday, and everybody should take a look at. It's stunning. So that's a long way around the barn, but we've come very far. We've come very far on this journey, but not nearly far enough. And I'm hoping that with the continued momentum plus the catalytic efforts of this foundation, we're going to get closer to where we should be.
David, we're going to have on the program soon, aren't we? She's doing such great work.
Oh, Mike, I'm just looking at the new website. I hadn't seen it. Wow. Holy smoke.
Yep. I got to check one.
Goodness. Mike, just as you were talking, I remembered, and I don't remember the last time that this was in my as clear, but Eduardo, I think it was at the Action Alliance, and he said, I'm not so much against suicide. And I said, okay, where's he going with this? And that's when he said it. He said, as much as I am against someone dying alone and in despair. Again, he may not have used those exact words, but those were the words that Jan used.
Yes.
And have created this vision. So, Mike, you start off in DD and management. You land up leading the Mental Health Commission under George Bush. Where did suicide prevention come into this? Your interest in it? I think it was even in that early 2000, was that 2003, Mike? That suicide prevention was already in that report. Where did that happen for you and your interest and dedication to that work?
Oh, boy. Well, the short answer to that is that I was allegedly in charge of these mental health systems where people in pain were set, and a lot of them were dying in our care. And we didn't know what we were doing. And therapists weren't trained and supported in what to do. So from, that's one part of the answer. And then another part of the answer, of course, is how Dr. David Satcher, Surgeon General, who, of course, produced the first Surgeon General's report on mental health, also led and supported the adoption or the development of the first national plan for suicide prevention, and which came out again from the Office of the Surgeon General, as well as SAMHSA. And so, the combination of that experience of mine, having incident reports come across my desk, he denied suicidal ideation before he died, or we had no idea. And this is in spaces and in sectors and places where we should have been attending to that pain. So you put those two things together, and it just lit a spark. I will take some pride in the fact that at the very beginning of the report to the president from the New Freedom Commission, that the first set of recommendations talked about advancing the national strategy for suicide prevention and creating a guidance group to advise it, which then happened 10 years later under Pam Hyde's leadership when the Action Alliance got created. So it's a combination of experience and leadership. And the truth of the matter is that the fact that we put that in the report, one of the dozen or so expert papers that the New Freedom Commission commissioned on topics was on suicide prevention by Eric Kane, and we're in discussion with leaders like Jerry Reed, who I think Jerry Reed whispered in my ear that really need to say something about this national strategy and to say something about the need for a national guidance group. So these themes and strands come together of motivation and learning and advocacy and platforms. And I end all that thinking we've come a long way, but we have a long way to go.
Mike, you noted something in what you were saying that reminded me of another area of many of our areas of agreement. When I first met you, and I really appreciated this about you because I saw it the same way, was that as a behavioral health commissioner, you began to see suicides in the way that we see homicides, and how that's a failure of the criminal justice system. And it is a failure of the mental health or behavioral health care system, suicides. That means we own the problem and we have to address it. And that's what you did, was taken on.
Well, Mike, so we've done together. Yeah.
I have so appreciated your leadership and the way that you have catalyzed this movement. And there's so much of the way that we even run meetings. I know myself, I think through the way you bring everybody in the room into the mix, and that learning, empowering, grabbing all the talent together and driving it forward has been so inspiring and moving, and so appreciate you and the inspiration you bring to this work. It's been great having you on the program today. But John, that brings us to the incredibly true tales of Behavioral Health Link.
Uh-oh, here they come.
Well, today I want to go back to 2004. John, we revisited 2005 and the devastation of Hurricane Katrina and the impact on Georgia. But in 2004, the year prior, we had 4 hurricanes hit the Gulf and Atlantic southeastern United States, and all 4 converged their paths through Atlanta. They were Charlie, Francis, Ivan, and Gene. And they all, in that August and September timeframe, had impact on this deluge of rain that just came through again and again and again, and reminiscent of Helen and Milton back to back for Florida. But I remember we were in the Citizens Trust Bank building, operating the crisis and access line for most of the city of Atlanta. and had to vacate the building because the water was in the parking garage and in the elevators, and the fire departments came. And thinking now, even still, we have a lot of our corporate partners are in the Augusta area. And today, Mike, I talked to one of our colleagues who still doesn't have Wi-Fi or cell service at his home, and has been without food, water, and fuel for a lot of this last week. Or a couple of weeks now since Helen hit. So, John, the convergence of crisis and this disaster space, which we've hit on a lot, reflecting on all those impacted by Milton and Helen again today.
Yeah, and David, as we've said in the past, that there's, when disasters affect a community, you need a community health response, and specifically community mental health response for people who are affected emotionally by the losses in a disaster. And there's nothing better than having a crisis center in the middle of that to kind of play air traffic control and help people find the help they need in addressing those losses. Because even getting the basic needs met, which is first and foremost post disasters, it's recovering from the losses. Once you get whatever you can back and realize there's certain things you're never going to get back, and that while other people move on, you're still stuck with these feelings that you can't get rid of. And that's really where the behavioral health care system and crisis centers and the work that we do really makes a difference, David.
And John, that brings us to a real need for some plain truth.
Well, I'm happy to give you a little bit today, and we've got, Mike Hogan is one of the great truth tellers. So I'm happy to share a little plain truth with you all. Really in praise of people like Mike. Public health leaders have described our behavioral health care system as broken for many decades. And a few have been doing whatever they can to transform it. And it hasn't been easy. But recently, as you were just talking about with the ChatGPT, David, we've seen that there's a little bit of grease on those rusted wheels. The sudden prominence of crisis care in 988, the growing application of technologies and care and coordination, and the voice of champion leaders across states are creating a long dreamed for paradigm shift in behavioral health. We mentioned earlier in this podcast about JFK signing the Community Mental Health Centers Act in 1963, but the year before that, a philosopher named Thomas Kuhn introduced the concept of how revolutions in science disrupt the status quo to create a new paradigm. Kuhn's theory applied to the earthquake-like transition from Newtonian mechanics to quantum physics, and demonstrated how outsiders who challenge existing norms can shift thinking. Their ideas and approaches gain traction through champions, respected figures within the system who build credibility for these new approaches. Outsiders and their ideas often go unnoticed until a crisis forces the need for new solutions. In times of crisis, systems must change, and innovative technologies or ideas from outsiders are more likely to be embraced by champions, especially if they offer immediate large-scale impact. Now, in our field, we've seen how crises have had significant change being driven by them. The influx of evacuees to Georgia after the Gulf Coast hurricanes in 2005, David, led to the creation of the Georgia Crisis and Access Line, the nation's first statewide crisis care system in 2006. And after the tragic theater shooting in Colorado by a man with serious mental illness, Colorado developed its own statewide crisis system shortly thereafter. The global pandemic spurred the widespread adoption of telehealth for mental health care, expanding services beyond office visits to reach people in their homes. Rising suicide rates in this century nearing levels not seen since the Great Depression prompted Congress and the FCC to assign a new three-digit number to the National Suicide Prevention Lifeline, increasing access to crisis and suicide prevention services like we've never seen before. Now, when these crises happen and the spotlight shines on outsiders to bring the new ideas and be ready for their close-up, it's great to have champions already engaged and ready to give a credible platform to these voices. It's worth taking time today to recognize a few of the major leaders among this century's state behavioral health commissioners that have led the way towards systems transformations via crisis care. And one of the most prominent of them is obviously our guest today, Mike Hogan. Now, when Mike was Ohio State's mental health commissioner in 2002. As we were talking earlier, you also chaired the president's new Freedom Commission on Mental Health. And they were assigned the task of telling us how we should improve the nation's mental health systems. And that report, Mike, you and your folks wrote that traditional reform measures are not enough to meet the needs of behavioral health consumers and families. To improve access to quality care and services, the commission recommends fundamentally transforming how mental health care is delivered in America. Now, determined to see this transformation happen, Mike, you drifted towards championing non-traditional approaches where you thought you could make a difference, serving as a commissioner of 3 states and now working well beyond those confines. And fortunately, you didn't toil alone, as you often say. We did these things together. But ever since the Lifeline grant was awarded in 2004 to back when we were called, now we're called Vibrant, but Mental Health Association of New York City, the National Association of State Mental Health Program Directors has been a critical partner in that grant. SAMHSA's Richard McKeon told me a while back, he says, John, the inclusion of NASHBID as a partner in your 2004 proposal was brilliant and was key to your being selected to run the network. But it was actually a stroke of luck. Our organization executive director just happened to meet NASHBID's executive director, Bob Glover, at the conference a year before, and they hit it off. And they said, well, we should find a reason to partner on something sometime. And then a year later, sure enough, they did. And it might have seemed a little odd to some of NASHBID's member commissioners that Bob would sign them up as a primary partner with us on this national hotline grant, because after all, crisis services and crisis hotlines were not prominently on the minds of state mental health authorities in 2004. The Freedom Commission's report mentioned nothing about crisis services, and even the federal government's first national strategy for suicide prevention in 2001 failed to mention crisis hotlines among their recommendations for effectively preventing suicides. But some state commissioners advocated for expanding crisis and suicide prevention services, and Bob Glover made sure that they connected with us outsiders in the Lifeline. And these NASHBID meetings were where I met this very supportive commissioner from Ohio and later New York, Mike Hogan. And in 2007, David and I gave a presentation to the NASHBID conference with Georgia's visionary commissioner at the time, Gwen Skinner, a vision that was also developed by Georgia's Wendy Tygreen. And we recounted the establishment of the nation's first statewide air traffic control crisis care system, which was coordinated through BHL's operated Georgia Crisis and Access Line. Several commissioners were really interested in the idea. They were following up with us, but the Great Recession of 2008 struck, and states were forced to cut about $4.5 billion in mental health services over the next 4 years. But state commissioners do Houdini-like work with the funds that they have to juggle the priorities of many stakeholders, and they typically must go where the funding streams are naturally flowing outside of their tight state budgets, typically from the federal government. But soon after the recession receded, Arizona's Tom Betlock began in 2015 to show other state commissioners how Medicaid could be braided with other federal, state, and local funds to support innovative crisis service programs that continue to lead the field today. The work in Georgia, Colorado, and Arizona acted as state models that NASHBID celebrated at their national conferences. But it was the persistent voices and actions of NASHBID's executive directors, first Bob Glover and then Brian Hepburn, and the nation's only serial commissioner, Mike Hogan, who were the primary state crisis care champions. They laid the groundwork for today's state leaders who are now transforming their crisis and behavioral healthcare systems. And as commissioners, both Brian and Mike made funding local crisis hotlines a top priority in the states, and both served as crisis chairs of the Lifeline Steering Committee for 2 years. Mike went on to be a major force, as we know, with the Zero Suicide movement, while Brian continued to work alongside Vibrant and SAMHSA to steer NASHBID members towards preparing for 988's launch. As Mike's new Freedom Commission report concluded, our system was broken, and it would take non-traditional approaches to transform it. The many ways in which we are seeing this transformation happening is the stuff of future podcasts, but suffice to say for now, when your system is in crisis, perhaps fostering crisis systems may be your first step towards pushing it in a new direction forward. I just got to thank you, Mike, for helping us be here today.
You're way too generous. You guys have paved this road.
With
So,
your
John-
help, so many more.
John, that's some plain truth. And I think if we're talking about, the numbers of copies of who moved my crisis cheese, were tallied up. Mike Hogan, Brian Hepburn, certainly responsible for selling more of that book than anyone else. So thanks so much for our friend and mentor and colleague Mike Hogan for joining us today. Join us next week when our guest will be Mike was referencing the indefatigable Lloyd Sederer. We're going to have a Spartan, ultra Spartan champion and star of our Moving America's Soul and Suicide documentary, Allie Robinson, join us. So that's going to be great. Please join us again next time. Remember, every story, every person, every crisis matters. And we'll be back with you next week on the Lifelines.